Hello friends, good evening. Now we'll be discussing about damage control surgery versus total early care. So we have already discussed about damage control surgery in detail, and now we'll be discussing its comparison with early total care, which is used in trauma patients. And this article has been made from Love and Bailey, and along with that few articles on internet. So without any delay further, let's get started. So damage control surgery, as we know that when the patient is severely injured due to any sort of trauma and has unstable physiology, and if we go for immediate extensive definitive surgery, they have poor outcomes. So we have to think of some other alternatives where there was rise of damage control surgery. So it is indicated in severely traumatized patient with impaired physiology. So in such cases, if we go for prolonged surgeries, it further causes trauma, that is called the second hit, where as the first hit is the trauma itself, and then the surgery causing the second hit trauma, then the immune dysfunction and physiological derangement. All these conditions further worsens by the prolonged surgery, and it leads to a dangerous cycle of acidosis, coagulopathy, and hypothermia, which is a triad of death resulting in organ failure and death. So in such cases, it is better that we go for damage control surgery or damage control operation, which is indicated here. So damage control surgery is indicated and focuses on rapid life saving and limb saving surgery, where we focus on hemorrhage control, decompression like craniotomy, fasciotomy, or abdominal decompression, revascularization of ischemic organ or limb, removal of any contamination due to rupture of hollow viscus or bladder, and we delay the definitive reconstruction until the patient is stabilized. And the abdominal decompression syndrome damage control surgery, it involves packing of the bleeding areas, hemorrhage control by proper vascular control, and debridement of the dead necrotic devitalized tissue, and if there is any foreign body, it has to be removed. In orthopedics, damage control surgery involves debridement of open fractures, temporary splinting, and decompression if needed in the compartment syndrome. We can even consider amputation over revascularization in severely traumatized patients. So it has to be individualized. So now this was about damage control. Now we see early total care, that is contrasting to the damage control surgery. So it is suitable for most trauma patients who respond well to resuscitation. So the patient who are physiologically and vitally stable, they can be taken for early total care. And some of the physiological indicators which are used for early total care includes that heart rate is less than 100, blood pressure and respiratory rate are normal, urine output more than 130 ml per hour, body temperature is normal, there is no hypothermia, that means the temperature is more than 35 degrees Celsius, normal blood gases, no acidosis, normal coagulation profile, and normalizing lactate level, that indicates good tissue perfusion. So abdominal early total care involves definitive repair or reconstruction of the injured organ, and in case of orthopedics, early total care involves definitive fixation of fractures within 36 hours generally, and it helps and facilitates early nursing, better care, early mobilization, and reduced complication. Now we also see some physiological assessment, that is the lactate level, which is very important aspect of the early total care and damage control surgery. So if the lactate levels are normal, less than 2 millimole per liter, we can consider that the patient is well resuscitated and is suitable for early total care. If it is elevated more than 3, it is suggested that either the patient is under resuscitated or may require damage control surgery if the surgery is urgent. Or we can also think about whether we can go for further resuscitation. If it is in between, that is 2 to 3 millimole, we have to consider the trend and other physiological parameters. And if it is more than 5, then we definitely have to go for damage control surgery. So the decision of whether to go for damage control surgery or early total care has to be made by the senior most doctors in the team, the surgeons, anesthetists, and the critical care physicians, and that will give us the best outcome. And then we have a criteria for the borderline patient who are neither fully stable and neither completely unstable. So the criteria is polytraumatized patient with injury severity score of 20 and an additional chest injury of AIS-2, polytraumatized patient with abdominal pelvic trauma with initial hemodynamic instability, systolic blood pressure less than 90 mm of Hg, patient with injury severity score of more than 40 in absence of chest injury, and bilateral pulmonary contusion present in chest X-ray. So these patients are specially considered for early total care, or as the new concept goes, of early appropriate care or safe definitive surgery, but it has to be individualized. Now we see the flowchart which is helpful for early total care, that the trauma is the first hit scenario. Then we go for assessment and resuscitation, reevaluation of the patient, categorization of patient depending on the clinical condition, whether the patient is stable, borderline, hemodynamically unstable, or in the extremes. If the patient is in extremes, then we have to consider second hit by definitive surgical. In all cases, rather, stable, borderline, unstable, and extremes patient, we have to consider that the impact of second hit due to any definitive surgery within 2 to 4 days of trauma. And in cases of extremes, that is the patient is very sick, we have to go for splinting, external fixation, or immediate damage control for contamination or hemorrhage control, and then manage in ICU. If the patient is hemodynamically unstable, we take the patient to operating room and go for damage control operation and further manage and resuscitate in ICU, followed by, after stabilization, definitive surgery. In case of borderline, we control the hemorrhage, chest compression, decompression as per need, and manage ABG and urine output. After that, if the patient is stable, then we take the patient for surgery with early total care. And if even after that the patient is unstable, we take the patient for damage control surgery, damage control operation. And as if the patient is stable initially, we can directly take the patient to OR and go for damage control surgery. That is, will be early total care. So external hemorrhage and chest decompression are considered before going for surgery here in case of borderline patients. So that is a new aspect. So we can consider it for taking patient for early total care. So this was all about early total care and damage control surgery in comparison. Hope it was helpful, and please like, share and subscribe, and keep studying, keep growing, and never give up, because great things take time. Thank you for watching. See you in next video soon.